dreams. And a lot of us dream. Some people think they don't dream or they can't remember their dreams. Some people have very, very vivid dreams and can remember everything when they wake up in the morning. We don't really quite understand dreams. We can guess and postulate as to what they're about. But we think that this cycle is very important for our brain and its rest. And our sleep essentially goes through these cycles about 4 or 5 times during the night before you wake up. So how important is sleep? Now, I've already said that we all sleep. We know it must be pretty important. We know that we can't survive without sleep. And just to test that out, in 1963, this guy, Randy Gardner, he was a university student, and he stayed awake for 11 days. Didn't go to sleep. They just kept waking him up, and that's the world record for the most amount of time that someone's been awake. But by the end of it, he was having hallucinations. He was seeing things that weren't there. His speech was slurred. He couldn't do simple maths equations. And he was actually very, very sick. And they let him sleep, and he slept for about 2 days after that. And then the Guinness Book of Records said, you can't do that anymore, it's too dangerous. So it's obviously very important for our bodies. And it's important for a number of reasons, because sleep is when we recharge and we rejuvenate our mind and our body. So we do things like learning and memory consolidation, so that's why it's important when you've got kids and stuff going through school. They need to sleep so they can learn all the things that they learned during the day. Emotional regulation, we think that's very important, particularly with dreams as well. So in your dreams, you're normally seeing things that you've experienced before, random things in your life. It doesn't always make sense, but that's your brain just trying to file what's happened through your life and putting it into different sections and actually processing those emotions and those feelings and those memories as well and storing them away. And it's extremely important for mental health. Our body also undergoes repair. So our physical body, so you have hard days at work or muscle injuries, it all recovers during your sleep. Metabolism, so that's how we digest our food. So we eat throughout the day, we obviously don't eat at night. And then our body processes that food, puts some into the liver or into fat for storage, into muscles for energy for the next day. Immunity, so our immune system is very reliant on having good sleep, and we all know that when we have poor sleep, we're more likely to get unwell. And also for growth, particularly in kids, teenagers, that's when you grow overnight. It's also very important for your focus and concentration. Again, something that I'm sure everyone has felt. If you've had a poor night of sleep, work the next day can be very, very tricky. All right, so how much sleep do you need? It's a very common question that I get asked. What's a normal amount of sleep? How much should I be sleeping? So this graph here essentially just shows throughout the life cycle, there's a diminishing amount of sleep that's required. And we all know this again from babies. You don't need, you have a lot of sleep. It's all broken up, but they sleep for long periods of time during the day. As they grow up, they're still sleeping a fair bit. And then through teenage years and young adult years, it's about 7 to 9 hours of sleep. And then there's potentially most of you guys here where retirement is looming. You might have already retired or you're close to retirement. And it's also a really important part of your time, is that unfortunately this is also when other health problems can occur as well. It's also the most common problem that affects sleep. So what are the things that can impact your sleep? We've talked about good sleep. What are the problems that you can have? And the way I like to think about it is that you have not enough sleep, too much sleep, and poor quality sleep. So not enough sleep is conditions like insomnia, which we're going to talk about, which is difficulty sleeping or maintaining your sleep. Sleep deprivation, again, that we've gone through, so jet lag, when you travel to Sri Lanka and back and you have jet lag and your sleep cycle's all up and down. Shift work is very common as well, so people who do evening shifts or night shifts, nurses, etc. Medications, so things like prednisolone, many of you have probably been on, they can cause you to not have enough sleep because it keeps you up. And then on the other end, you have too much sleep. So you have things like idiopathic hypersomnia and narcolepsy, which we're not going to talk about today. They're very rare conditions, and you may or may not know people with this, but these are patients that are sleeping all the time. So they're sleeping 15, 16 hours a day, and it's very, very hard to function. It would be very rare if you had those conditions. And there are some medications that put you to sleep as well. So we've all seen on the back of some of the medications, particularly pain medications, where it says don't operate heavy machinery, don't drive after taking this, because it makes you sleep. And then in the middle, we've got this important bit about the actual quality of sleep. And we're finding that it's not actually the time of sleep that's important, but also the quality of the sleep that you get. So we're going to talk about sleep apnea, or obstructive sleep apnea, OSA, nocturia, which is going to the toilet frequently overnight, and restless leg syndrome. They're probably the three most common things that I see in patients of your age that present through the sleep clinics. Then there's other things like pain, so having chronic pain issues is going to disrupt your sleep, stress and anxiety, the actual sleep environment, so where you're sleeping is very important as well, and how comfortable you are. Those chronic illnesses, so diabetes, heart issues, all those things can impact your sleep as well. Parasomnias I won't talk about. Parasomnias are things like sleepwalking or sleep talking. Generally don't affect your sleep too much. Again, rarer as you get older. And something called REM behaviour disorder. I won't go into too much today, but essentially in REM sleep, which is actually rapid eye movement sleep, the rest of your body is paralysed when you're having a dream. So that's by design, because if you're having a dream, say of someone chasing you or a lion chasing you, you don't want to act out that dream because it will disrupt you, you might injure yourself. So you're actually paralysed during your REM sleep, except with your eyes. So REM behaviour disorder is an issue where patients don't have that paralysis and they're actually falling out of bed or moving their arms and legs. So if that's happening to any of you, please see your doctor. It's rare, but it can occur. Alright, so I hope you're following so far. Obstructive sleep apnea, this is what I'm going to talk about most of the talk and focus most of my energy, because by and large it's the most common issue that affects Australians in regards to sleep. So there's 1 in 5, so it's probably about a quarter of you already having sleep apnea, whether you know it or not in this room, and a portion of you hopefully on treatment. So obstructive sleep apnea is repetitive, partial or complete closure of the upper airway during sleep. So your upper airway is essentially your neck, and closure of it is obstruction or blockage of your upper airway. So this can happen multiple times during the night, and when that occurs, obviously the oxygen to your lungs and the rest of your body is reduced. And your brain doesn't like that, your brain likes oxygen. So what it has to do is send signals to your neck and the rest of your body to actually wake up. You may not physically wake up, but your brain is constantly working. And it's obstructing and then waking up, obstructing, waking up, constantly overnight. And that's what obstructive sleep apnea is. Now, as you can imagine, that puts a lot of stress on the heart and the blood pressure, because you're meant to be sleeping. You're not meant to be worrying about oxygen. You're meant to have a nice breathing sort of oxygenation throughout the night. And it causes a lot of fragmented sleep where it's very interrupted. And there's lots of severities, so there can be mild obstructive sleep apnea where this happens 5 to 15 times an hour, or moderate 15 to 30 times an hour, or severe where it's happening more than 30 times an hour. So what are the risk factors? So the first thing is anatomy and genetics. Anatomy is the shape of your body and your airway, and genetics is your genes, what you get from your parents. So that determines what the shape of the airway is, and things like enlarged tonsils. So if you look at this picture here, this is relatively normal, so you can see the back of the airway. Whereas if you have class 4, we're called Mallampati, you can't see anything at the back there. So you can see that there's a blockage there already. So this gets worse when you go to bed. Neck size is very important as well. So if you have a big neck, or if you have a face where your chin is pushed back like this lady here, you can see that all those things will affect your airway and the ability for it to stay open overnight. Particularly when all your muscles relax, and if you have excess weight, then that's going to contribute. So that's why the second point is weight. Other things like increasing age, alcohol, sedating medications, and sleeping on your back are all going to increase these risk factors as well. Alright, so what are the symptoms? How do you know if you've got obstructive sleep apnea? You may not know, and a lot of patients are walking around not knowing that they've got sleep apnea, because we really only know until we do a sleep study and test you, which we'll talk about in a tick. But have a think about some of these and see if it applies to you or anyone you know. So snoring, and then interrupted by pauses is very important. They're the actual apneas. Apnea means that breathing has stopped. Waking up unrefreshed, so you have a good night's sleep and you wake up and you still feel like you're not refreshed and ready for the day. Headaches in the morning because your brain has not had enough oxygen overnight. Dry mouth because your mouth has been open the whole night. Excessive daytime sleepiness. So this is a really important one. Everyone's tired these days, we all know that. Everyone's got work and busy lives and they think they're tired, but this is much more tiredness than a normal individual, and actually sleepiness. There's a bit of a difference between tiredness and sleepiness. So these patients are falling asleep all the time. and poor concentration and memory. So we use different scales and questionnaires to try and figure out who these patients are. So one of them is called the Epworth Sleepiness Scale, which is in the green over there. Hopefully you can see some of this, but I'll read out most of them. So these are essentially a scale between 0 and 3 in terms of situations where you would doze off or fall asleep during the day. So for example, sitting and reading, if you fall asleep a lot, you get a 3 for that. Other ones are watching TV, sitting inactive in a public place, lying down in the afternoon to have a rest. Then there's high-risk ones like sitting and talking to someone, sitting quietly after lunch, and particularly in a car, if you're stopped at the traffic light and you've fallen asleep, you get a 3 for that, then it's very high risk. So if you add up those scores and it's greater than 8, you're very high risk of having obstructive sleep apnea. And that's not a normal amount of sleepiness that we expect. Okay, so diagnosis. So, as I said, the only way to actually figure out sleep apnea is to send someone to a sleep lab. That's what most of my job is, and some GPs are doing this now as well. So there's a number of ways to diagnose sleep apnea. The first one is in a hospital sleep lab. So like this guy here, you get wired up, you get nasal cannulas here on your nose, you get sensors on your chin, you get brainwave sensors up here, you get bands, you get ECGs under his shirt here, and it gets connected to this device here. There's a sleep scientist that stays there overnight, and there's video as well. So we get a whole bunch of information, and it looks very scary, but I promise you it doesn't hurt. And most patients are able to get some sleep overnight. These days we're getting more and more home sleep studies, so that's this gentleman on the right here. So this is a device that you go into a sleep lab and they put it on for you, and it's got less wires, but still a fair amount of sort of setup, and they send you home and then you sleep in your own bed with the device on. And then when you wake up in the morning, you return the device back to the sleep lab. And then we analyse all the data. So just some of the differences, obviously in a hospital it's a different bed compared to your own bed, and some people like to sleep in their own bed. Cost-wise, publicly there's options for both of these, so it's both funded by PBS, NDS, so you don't have to pay if you go through the public system. Obviously you can get a private sleep study as well if you want to use your health insurance. And home sleep studies, now GPs can actually refer you to get a home sleep study as well. And a lot of people ask me about the accuracy, and now they're pretty good. The accuracy is pretty good for home sleep studies for obstructive sleep apnea as well. So you're getting one of these tests if you think that you've got obstructive sleep apnea. Then when you get a test, you get a graph like this, and this is my job to look into these graphs and figure out what's going on. So I'm going to start off with a normal graph, and it's quite complex, so I won't go through all the data. You might just be able to see my cursor there, but essentially the green and the blue and the red are different stages of sleep, and the red is the REM sleep, and it works as a graph going across that way. And the oxygen line is this blue line over here, and that's a very normal oxygen looking line. It sits at about 100. I'll show you what abnormal is, and this will make much more sense. So this is an abnormal sleep study, and to make it even easier, I'll circle the bits that are abnormal. So those bits that I've circled there are the oxygen dipping, so that's what I can see on your sleep study. And those little blue lines at the bottom there are these little obstructive events. So that's when your airway's actually closing or almost closing, and the sleep scientist sits there and actually counts these events, and we can catch this all on the sensors from the sleep study. So we get a whole bunch of information about the sleep architecture, what your oxygen levels are doing, how many times you're waking up during the night, and how severe your sleep apnea is. So that's severe sleep apnea. That's a very bad example of sleep apnea. So what's the point? Why am I here? Why am I talking to you about this? Why should you even get tested and treated? Most people will live their whole life without obstructive sleep apnea assessment or sleep studies. So first of all, it's probably going to cause better sleep overnight if you get looked into and treated, and also for your partner as well. Less snoring, so that can be one of the biggest problems that I see, is that a wife or a husband will come in and say that my wife or husband is snoring, can you please fix them? And once you fix that, you'll become a relationship doctor as well. Reducing daytime sleepiness is a very important factor. So particularly if you're still working and you've got a busy life, you don't want to be sleeping and tired all the time. This actually can change a lot of people's lives if you start treating their sleep apnea. Increasing those energy levels and improving memory and cognition as well. And then there's long-term benefits as well. And again, this is the most important part, I think. So remember how I was telling you about stress on the heart and the blood pressure if you've got sleep apnea? That's happening every night. Every night that you go to sleep, if you've got obstructive sleep apnea, that's occurring. You have no choice because you're asleep. So it obviously puts a lot of pressure on your cardiovascular risk. We know patients with untreated obstructive sleep apnea develop hypertension or high blood pressure, and potentially other cardiac problems as well, like heart attacks and strokes. So it is a risk factor, just like your cholesterol, or your diabetes, or your weight. Obstructive sleep apnea is now a very important part of your overall health and your heart health. And the best part is that there are excellent treatments and very safe treatments as well, which I'm about to go through. So number one treatment is CPAP therapy. Again, I know there are people out there on CPAP, and probably about a quarter of you should be on CPAP therapy. CPAP is continuous positive airway pressure. So I've got a picture of it here. This is a guy with a CPAP machine on, a bit of a demonstration. It's a mask, it's got a tube and it connects to a machine. These are what the actual machines look like. And the machine, all it does is delivers the pressure. It's pretty much just plumbing. It gives pressure for the upper airway and splints it open, just like if you blow a little bit of air into a balloon. By doing that, it overcomes any obstruction that was going to happen with your obstructive sleep apnea. So it works extremely well. There's gold standard evidence to say that obstructive sleep apnea can essentially be treated and cured with CPAP therapy. And it has very minimal side effects. It's not a tablet. You don't need to worry about any of the side effects. The main thing is that you can sometimes get pressure injuries. So mask fit and mask choice is very important. Now, it does take a while to get used to, and I always tell patients that it can be quite daunting and scary to say that you've got to go to sleep with a mask on your face. But I guarantee you'll get used to it if you've got severe sleep apnea. And you can ask your friends. There's a secret society of people on CPAP. I know there are people in here. And talk to them about how their CPAP experience was if you have any doubts. They'll probably tell you the first couple of nights, terrible, couldn't sleep, you feel really bad. See people nodding. After about a week or two, you're feeling a bit better, you're noticing that it's working well for you, you're feeling more energy, or you've got less sleepiness during the day. After a month, 3 months, you're feeling good, you're using it every night, and the average is about 4 hours. After a couple of years, you can't sleep without it, I guarantee it. I get patients here who can't sleep without their CPAP machine, and it just shows how good and how positive the treatment is. The machines track all the data as well, so our new fancy machines, they look at how long you've kept the machine on, what the leak is like, what the pressures are like, and it can also tell us what your sleep apnea index is like. So I was saying over 30, for example, is severe sleep apnea. I can generally get that put between 0 and 1 for most patients pretty easily with CPAP therapy. So extremely positive therapy, and this is probably the most important slide of the whole talk. So if you're falling asleep, just remember this slide. Just some practical notes, so I thought this might be good. So CPAP therapy, everything has a cost, and it is very expensive. So a CPAP machine costs about $1,000, $2,000 if you just go to a shop and purchase it. But there are ways around it. So what normally happens is a patient has a sleep study, either through their GP or I organise it. They've got sleep apnea. I tell them to trial a machine, so you get a 1 month trial with a machine and a mask. It costs about $150, $180, very reasonable. That period is for you to get used to the machine and show us that it's actually helpful for you. Then we look at the data and make sure that it's actually working for you. And then certainly if you have the money and don't have any other options, you purchase it. But if you've got a pensioner's card and a Centrelink card, because you've paid your taxes all your life, you've got to utilise that. And you can apply through like Alfred Hospital or Monash Hospital and you get a machine essentially for free. It costs about $80 for the admin fee. And then you also get your Centrelink card, and I fill out a special form for you to say that you need CPAP therapy, and you get $190 to cover the cost of a mask every year until you have CPAP therapy. So it essentially works out to be free. You can see there's a number of masks. I've just put those up here as well. So this is the most common one that you start off with, the full face mask that covers your nose and your mouth. It looks very scary, but that's probably the best one to start off with because we don't know if you're breathing through your nose or your mouth when you start. And then you can move on to one of these smaller ones, like a nasal mask up here, what's called nasal pillows, or this one of the smallest ones we've got there. So you can see that they're getting smaller and smaller, quieter and quieter, and less invasive. Number 2, treatments. So say you can't use CPAP, or there's an issue, or you don't want to use CPAP, I recommend a mouth guard. This is good in mild to moderate sleep apnea. As it becomes more severe, it becomes less efficacious. It doesn't work as well. These are special splints. That's an example of one of the new ones that we've got. They're relatively small and they fit in your mouth and they move your jaw forward. So sort of in that second picture, you can see that that jaw is brought forward and that blue line is the oxygen going through. Again, very expensive because they're dentists and they charge a lot of money. So if you go see one privately, they're over $2,000 and you can't get anything back from Medicare. If you go through the public clinics like the Royal Dental Hospital, it's about $600. It's probably the cheapest you can get it for. The thing with that is you can't trial it because it goes in your mouth, so you can't return the device. So you have to go get it made. Hopefully it works for you, and hopefully they've got a refund policy. So that's why I always say that you should try CPAP therapy first. Weight loss. So we talked about weight being one of the important factors. It is genetics, it is weight as well. So if it's a combination of both, you want to try and treat the weight. You want to try and treat the weight for many reasons as well to reduce your cardiovascular risk. So we all know about diet and exercise, very hard to lose weight. What I mainly want to talk about is the third one here. There's surgery as well, which I think is probably going to be irrelevant in a couple of years because of number 3, weight loss injections. So you would have heard about these, GLP-1 agonists or Ozempic injections as such. GPs are well aware of this now. They're going to change the game, I think. I think we're going to see obesity levels really plummet once we get patients on this medication and once Medicare realises that they should pay for this medication. Works extremely well. I've seen patients lose 20, 30 kilograms of weight without doing anything except being on these injections. I've seen their sleep apnea completely resolve and come off hypertension, blood pressure pills, and completely change their lives. Now, it's not for everyone, and I'm not here to sort of advertise weight loss injections, but it's just the evidence shows that we're going to get better and better, there's going to be less side effects, and hopefully they're going to be available on the PBS, which means that it will cost the same as your other medications. Currently, the main issue is that it is costly, and you've got to ask your GP to get you a private script, and it can cost anywhere between $100 to $500 a month, depending on which injection you go for. But stay tuned. I think in the next 5 to 10 years, we're going to see a lot of patients just ending up on these medications because they are certifications. Surgery, I'm not going to talk too much about. So you can get surgeries to treat obstructive sleep apnea. A lot of them are very invasive, and the main thing is it may not actually work. So I only refer maybe 1 or 2 patients a year to actually get surgery. So we'll skip that. All right, so that's about obstructive sleep apnea. I'm going to move on to insomnia now. Insomnia is probably the second most common thing I see, and probably the most common thing for retirees and people as they get older. Insomnia is the difficulty falling asleep, so you go to bed and you can't get to sleep for an hour or 2, or whatever it is, or you get to sleep and then you wake up and you can't get back to sleep. And you wake up, you can't get back to sleep, or you wake up and you can't get back to sleep at all. So a lot of the causes are related to stress, anxiety, mental health. We all go through insomnia at certain stages in our life. Chronic pain is another big factor as well. So if you have knee pain, arm pain, hip pain, back pain, all those things, they affect your sleep quality and can cause insomnia. If you've got sleep apnea as well, we talked about that. Remember, every time you're waking up, that's going to interrupt your sleep, and you end up having a very light sleep instead of a deep sleep. And the manage for it is quite hard because there's no good medications just to say this is going to treat your insomnia. There are sleeping tablets, but they're never good to have in the long term. They're just temporary solutions. Melatonin is probably the only one that I would recommend to trial, and if you're over 65, you can just go to a chemist and you can get melatonin without a script. It's a natural hormone. If you remember back to the first slide, that's the hormone that keeps us asleep. And it works for some people, doesn't work for everyone. The main therapy is something called cognitive behavioural therapy for insomnia, which is essentially psychology. It talks about different aspects of sleep, and you can either do online courses or you've got to actually see a psychologist and they talk about this course with you. A really important issue, but it is awfully difficult to treat. Restless leg syndrome. So again, you may not have heard about this. This is a condition that again affects people, particularly as they get older. This is an irresistible urge to move your legs. And if you've got this, you'll know what this means. So it's an inability to stay still, particularly overnight. You're constantly moving your legs. It's worse in the evenings and the night, but can occur during the day. It disrupts your sleep. It can be very uncomfortable, cause pain and numbness and aches. And some of the causes can include iron deficiency, so you should be getting your iron checked anyway with your GP, but that's an easy way to fix it. Some medications can cause it, and sometimes there's no real cause, and it can be genetic. So there are some medications. It used to be something called pramipexole or Cifrol. If you're on that, that's one of the older medications, so ask your GP if you're going to change that. We're using more gabapentin and pregabalin. These are nerve tablets that essentially affect your brain and reduce your restless legs. Nocturia, another very common complaint that we get. So this is waking up more than once to go to the toilet. Obviously that disrupts your sleep as well, and that can cause sleep deprivation. So some of the causes include drinking too much fluid, alcohol, caffeine, particularly in the evenings, diuretic medications, so these are fluid medications that you might be on for heart failure, prostate enlargement and pelvic prolapse, so very common issues, diabetes and high blood pressure as well. And the management involves looking at the fluid and trying to reduce that in the evening, but the main management is actually addressing any urological issues, so for example for the men, prostate issues, addressing that, for the women, gynecological issues as well, and treating that as best as possible to try and make sure that your sleep's not interrupted by going to the toilet. Alright, we're heading towards the end now, so hang with me. Driving and sleep is a very, very important topic, and I'll tell you why. Sleep deprivation, just like that first guy that we talked about, causes you to reduce your driving performance and your concentration, as well as your ability to react, your reaction time. So sometimes it's similar to just being under the influence of alcohol. In Australia, 20 to 30% of all accidents that are fatal are due to people falling asleep at the wheel. Right? So it's about a third. And it's high risk if you live in a rural area where you've got long roads, very boring to drive on, long drives. The afternoon time as well is a very high risk period, just as you get sleepy. And they take it very seriously. Obviously, your GPs and doctors may have already brought it up with you, sleep physicians as well. We all have a responsibility to look after our driving. If we're on our roads, we are responsible for our car, but also the lives of others as well. So if there's a sleep condition such as obstructive sleep apnea, the recommendation is actually that you report to VicRoads and say that you've got sleep apnea, and then your GP or a sleep physician has to fill out medical reports to say that you're getting treatment for it and that it's looked after. You don't have to do that, but it's a very strong recommendation. It's more important if you're a truck driver or if you drive Uber, you're driving other people around, then it becomes more of a requirement, and there are different laws for commercial drivers. We can do special sleep tests as well, so sometimes we'll do a sleep test and then in the morning we have another session where we see how sleepy you are and we record whether you fall asleep in the morning. And yearly medical assessments are already talked about as well, so you have to get a form signed off at VicRoads, otherwise they can take the licence away. So just a very important factor to think about. Alright, we're almost at the end. So just some really practical sleep tips for good sleep. These are very generic. If anything I've talked about today doesn't apply to you and you have excellent sleep, just ignore the rest of this. Do whatever you're doing. But if you want to try and improve your sleep, I think some of the main tips that I recommend, having a routine, that's probably the most important one. So try have a time that you do go to bed and try have a time that you wake up in the morning and try to be as consistent as possible with those times. Devices we know we talk a lot about, especially with our kids, is to try and reduce screen time with phones and tablets and TV before we go to sleep. It's almost impossible to do that now. Having some sort of wind down routine before you go to bed, so whether that's reading a book or meditation, listening to music, whatever it is, just to disconnect yourself and turn off your mind is very important. The bed environment, make sure it's comfortable. So your bed, your pillow, the noise level in there, make sure everything is comfortable. The lighting, we talked about how important lighting is for that circadian rhythm. So at night time you want to have dim lights, and then in the morning time you want to be exposed to bright lights. Avoiding naps during the day as well, so you have this temptation if you've had poor sleep to nap during the day, but that can unfortunately cause you to have difficulty sleeping the night after. So try and avoid naps if you can. And avoiding coffee, I put tea there and I realise that you're all shrunken and drinking tea, so that's going to be tricky, but particularly in the evening, coffee is very caffeinated and will keep you awake. This one here is about if you wake up during the night and you're just lying there. That's one of the worst things you can do, just lying in bed not sleeping. you want to make sure your bed environment is for sleep. So as soon as you're in there for more than 20 minutes and you're not getting back to sleep, I tell patients to go to a different room, read a book, do something else until you're sleepy, and then come back to the room. And then treating pain and nocturia, I think, is something that we overlook a lot. If you've got chronic pain, nocturia, see your GP, get those things sorted, because it probably is affecting your sleep. Again, the number one main topic I think I just want to give away as the main message is, if you think you've got sleep apnea after all those things that I talked about, your sleep, or you know someone, your husband or wife, your partner or kid or whoever it is, talk to your GP about it. Because it's very treatable, we can diagnose it quite easily, and a lot of patients have come back and it can be very life-changing